Use of aqueous angiography to augment surgical outcomes of minimally invasive glaucoma surgeries. Aqueous angiography is a technique introduced in 2017 to study proximal to distal aqueous humor outflow pathways under physiological conditions in humans. We use 0.5% of endocyanin green dye, 0.1 ml of which is injected into the anterior chamber, and images of aqueous humor outflow pathways are captured by flex module of spectralis HRA-OCT by Heidelberg Engineering. This technique is now being explored for clinical applications to improve the success of glaucoma surgeries, especially minimally invasive glaucoma surgeries, that is MIGS. ICG dye injected into the anterior chamber and images captured using the machine. Aqueous angiography in non-glaucomatous eyes showing 360-degree high flow regions of aqueous outflow channels. Another example of aqueous angiography in non-glaucomatous eyes showing segmental pattern, that is high flow region in nasal and low flow region in temporal quadrant. Clinical applications of aqueous angiography are: it helps study the effect of minimally invasive glaucoma surgeries like bang and eye stent inject on aqueous humor outflow pathways. It helps discover the cause of failure of MIGS in glaucoma patients, which can then be corrected to improve their results. It also helps intraoperatively to assess the functionality of minimally invasive glaucoma surgeries and make surgical adjustments in the same sitting possible. This has been demonstrated by the following cases. Case 1 was a 58-year-old male with mild primary open-angle glaucoma with immature senile cataract. We planned for a left eye stent inject with phacoemulsification. Aqueous angiography was performed after insertion of eye stent inject. Intraoperative gonioscopic view after eye stent inject. One was inserted at 10 o'clock position denoted by the green asterisk, and the other was inserted at the 8 o'clock position denoted by the blue asterisk, showing clinically adequate positioning of both the eye stent injects. Aqueous angiography performed post eye stent inject. Comparative gonioscopic image after an eye stent inject and the aqueous angiographic image post eye stent inject showing visible collector channels denoted by green arrow near the 10 o'clock device and absence of collector channels near the 8 o'clock device denoted by the blue asterisk. This eye stent inject was adjusted intraoperatively in the same sitting. Moving on to the second case of a 62-year-old female with left eye moderate pseudophakic glaucoma. Pre-bang aqueous angiography identified nasal angle as being the high flow region. Bang was performed in the nasal high flow region. Post-bang aqueous angiography showed increased angiographic signals in the nasal region, indicating increase in the outflow. Pre-bang aqueous angiography showing high flow region in the nasal quadrant. Bang performed in the nasal quadrant, we can visualize the clear demarcation of trabecular meshwork due to green color staining by ICG dye. Post-bang aqueous angiography showing increased angiographic signals in the nasal quadrant, suggestive of increased outflow post-bang procedure. Moving on to our third case of a 56-year-old male with both eyes severe primary open-angle glaucoma with immature senile cataract. Aqueous angiography of the right eye prior to phacoemulsification revealed no flow of aqueous through the trabecular meshwork in superior temporal and inferior quadrants and minimal flow in the nasal quadrant. Hence, based on aqueous angiography showing severe lack of aqueous outflow through the trabecular meshwork, we planned for trabeculectomy instead of MIGS with phacoemulsification. Aqueous angiography in this patient. Endocyanin green dye is injected into the anterior chamber and enhancement of the anterior chamber is seen with an air bubble casting the black shadow in the center of anterior chamber, which is an artifact. A single collector channel is seen in superonasal quadrant with no collector channel seen in superior, temporal and inferior quadrants. Due to severe lack of aqueous outflow through trabecular meshwork, we planned the patient for trabeculectomy instead of MIGS with phacoemulsification. Through these cases, we would like to summarize that aqueous angiography allows for assessing the functionality of MIGS procedures like I-stent inject and make surgical adjustments in the same sitting possible as seen in case 1. It allows for MIGS procedures to be individualized to high versus low flow regions to improve its success, as seen in case 2. Aqueous angiography, by allowing assessment of aqueous outflow pathways, help take better decision for moderate to severe glaucoma patients whether to perform MIGS or conventional glaucoma surgeries like trabeculectomy, as seen in case 3. Aqueous angiography with minimally invasive glaucoma surgeries has the potential for causing a paradigm shift towards better success rate of MIGS procedures in future. Our take-home message is aqueous angiography is still a nascent technique but has great prospects in future to improve the success of MIGS in glaucoma patients. Thank you.